what we got. So we're going to get started with the program. Dr. Lisa Hofler, I met when she was a fellow in the Emory Complex Planning Department. So she is an associate professor of the Division of Complex Family Planning at the University of New Mexico School of Medicine. She holds degrees in chemical engineering from Georgia Tech. What's the good word? Where's Dr. Klein? She also received her MD, MPH, and MBA from Emory. And she did her residency at Beth Israel Deaconess in Boston and then came back for her family planning fellowship. She is the winner of numerous teaching awards and is highly valued in her institution. And she is one of ACOG's two members on the AMA CPT editorial panel. So it's a huge win. Don't inundate her with your problems after this, but we're so lucky to have her.
Good morning, everybody. Thanks for having me today. Thank you to the Georgia OBGyn Society. I was just texting Missy Kotke, who was my fellowship research mentor. By the end of this, I'm going to want to come back to Georgia. Like, I really miss it. This is my adult home. And so I'm here to talk today about what's new in coding. Coding and billing is both very technical and also like very hotly contested and legislatively, legally dramatic behind the scenes in a way that I didn't understand until I got involved. So you're going to hear a little bit about the drama and also what's new in coding. So here's our objectives. This is a CME talk. We're going to talk about what's happening now and maybe in the future that we know, and then we're going to talk about in the future that we don't know, which is the most exciting future. So let's get started down that path. So I have no financial disclosures. I'm actually proud that I have no financial disclosures. I will disclose I'm not a certified coder. I have not gone through that training to do all of the coding. But I am heavily involved. And I'm just going to say CPT is a registered trademark of the AMA, and I have not put any of those little symbols anywhere. So there we go. So my coding story starts in high school when I was a cashier at the grocery store. And who knows the code for bananas? 4011, right? Like, that's the code that everybody knows. But it was my mission back in the day when they didn't have UPCs on the fruits to know all of the codes so that I could be the most efficient checkout at Farm Fresh there was. And that, I think, has translated to today a little bit. But I told this story once, and someone was like, that's why you like all the codes, because you were a cashier. So as you heard, I went to Georgia Tech. I'm an engineer. I spent a lot of my adult training at Emory, for which I'm incredibly grateful. And I have one more disclosure that's not a financial disclosure, but Evan Schoenberg, who coded the ICD-10 Consult app, which is my favorite app for free for finding your ICD-10 code to link up. He was in both my Georgia Tech and my med school classes. And so good for him. He's an ophthalmologist now. But ICD-10 Consult is a great free app that will help you find diagnosis codes for those conditions you don't actually know what they are. And now I'm at the University of New Mexico, where I'm the clinical vice chair of the department. I do a lot of things, and I'm really excited in it. And it's been a really wonderful place to work for the last 8 years, and especially over the last 4 years when there's just been a lot happening in complex family planning. So let's get started with some codes. We have 2 exciting codes this year that went into effect on January 1st. The first one is the pelvic exam code. So pelvic exam, you would never be so excited as to get 99459. But the pelvic exam code is a big win for us and for everyone who does a pelvic exam. It's an add-on code that went into effect on January 1st. And so the idea, this is my happy dance, the idea with the pelvic exam code is that it captures the additional practice expense involved in a pelvic exam. So if you have someone who comes in with a cough, and you do an evaluation and management, you being maybe a PCP, there's not a lot of additional expense to that. But you have someone who comes in with a vaginal discharge, and you have to have a speculum, you have to have a chaperone, you have to have a light and gel and all those things. And so the pelvic exam code is intended to compensate for that, like, gender differential in doing a pelvic exam. So the pelvic exam code, super exciting. And so it covers all the supplies, like a disposable speculum or the sterilization of your speculum, and the room prep and the chaperone. And so it's an add-on code that adds on to your regular office E&M codes that you know. So 99204, 99393, all of the evaluation and management codes to the office. It doesn't include procedure codes. So procedure codes like a endometrial biopsy already has the speculum built into the payment for that code. But evaluation and management codes like everybody uses, not just OBGYN and not just those procedures. So it adds on to the E&Ms. And it gives you 0.68 practice expense RVUs. So no additional like work because it's part of a physical exam, but it gives you more payment to the practice for the work of doing a pelvic exam. And it's a best practice according to ACOG to document the presence of a chaperone or the patient declining the chaperone, but that's not needed to build a code technically. None of these pictures of New Mexico are my own, and so I put this little thing in there because technically it's not needed to build a code, and there's no consequences, I don't think, if you document you've done a pelvic exam. It's already in your exam section of the note. But Truth or Consequences New Mexico changed its name in the 50s to be to a game show called Truth or Consequences. It actually was called Hot Springs. It has amazing hot springs, but now it's TRC. And so I use it every time I need to talk about something that, maybe might have some consequences, but this one's not. Okay, so examples of how to use 99459. You have Sophia. This is a 43-year-old Gravi2 P2. She's an established patient here for a wellness visit. She's feeling fine. You do cervical cancer screen. You bill her preventive visit code 99396, and you bill the add-on code 99459 because you did a pelvic exam. Kayla, this is a 25-year-old G1P1. She's a new patient. She has a discharge. She's uncomfortable. You do a pelvic exam to figure out what's going on with the discharge. You diagnose trichomoniasis, and you bill the 99204 for the E&M and an add-on code 99459 for the pelvic exam. So pretty straightforward pelvic exam code. All of the codes that are new, I'm going to say a little thing about new codes. When I got super excited on January 3rd this year, I went to my coders and I said, pelvic exam, and they said this isn't in all the dictionaries yet for the payers, and that is true, and you should still bill it because it's going to be, and we have to use it. So I think that's another important thing, is that when new codes start, every year the payers have to kind of follow and figure it out rapidly. But 99459, excellent code to try to make more gender equity. Okay, the other super exciting win this year, which isn't just for OBGYN, is the longitudinal care code G2211. And you maybe have heard about G2211. This also went into effect on January 1st. This was a controversial code because the idea was CMS was trying to encourage longitudinal care so that you've got a clinician that you see as a patient ongoing, instead of calling and trying to find somebody and there's nobody around and you never establish care. This is an incentive for us to have continuity with patients, which we love and which patients love, and which the idea of the longitudinal care code sort of helps encourage that. So G2211 is for, like we said, longitudinal care. This also is New Mexico. And it is the place with the biggest sky and the most beautiful light that you've ever seen. Not to say that this humidity isn't my natural habitat, and like my skin and my hair love it, but New Mexico's nice. So G2211 captures the inherent complexity of the visit related to the longitudinal nature of the visit. Like the fact that you have a relationship with this patient is the reason that you bill this G2211. Right now it's a Medicare only code, and so I think that's an important context, is all the G codes are Medicare. So this would be really applied to your Medicare patients. And part of what happened in the last year when this code went into effect is the conversion factor, the amount that CMS pays per RVU, changed because they anticipated there would be more RVUs in the pool and that the G2211 would help redistribute to the people providing longitudinal care. And so if you are providing longitudinal care to a patient, either for a single serious condition or a complex condition, or if you're their primary touch point, you should bill this code too, because the idea is that's how you get credited for that longitudinal care, that relationship with the patient. So by not billing it, I think we disadvantage when there is a context that we could. So examples that they give in the bulletins about this include, if you're their primary care person, say you're someone's gynecologist, they're otherwise healthy, you do their annual screening labs and exams for Medicare, and you say, I am your primary care doctor right now. You have no medical issues, for example. So primary care is one example. And then the other example they give is if someone's got an ongoing complex condition, like HIV, and you are their infectious diseases doctor, and you take care of them for their HIV care, that is another example. And so we'll have some OBGYN examples, but those are the two that they give in the CMS bulletin. So the way that G2211 works, it's another add-on to an E&M code. The office and the outpatient codes. It's not the preventive care codes, though, because those already capture kind of that longitudinal relationship. But this is someone you see for their wellness visits, and they come in with periodic problems, and that's when you bill the G2211. It's got a third of a work RVU attached, so you can bump up your E&M by 0.33 work RVUs. Just by doing this, if you work in a practice that measures your work RVUs, and can only be reported when you do the E&M by itself. But you don't need to do any additional documentation, despite what our compliance department has suggested we write. So I'm just going to put that up there. It's in gray, and I think they're using that from a CYA kind of justification standpoint, but you don't actually have to. You just need to be providing ongoing care. So here's an example of someone that you would use in your practice potentially as an OBGYN, that I would use in my practice as an OBGYN. So this is Maria. She comes often for her chronic pelvic pain. We talk about how it's hard to have pelvic pain and it's painful, and we check on things and we make sure Maria's okay. But today she thinks she might have a UTI. And so I evaluate and manage the UTI, and lo and behold, I'd say, yep, UTI, I give her some antibiotics, and I bill the G2211. Because the complexity is not the UTI. The complexity is in my relationship with Maria and that longitudinal aspect of care that she trusts me and comes to me and knows that she has a clinician that will take care of her. And so it's about the doctor-patient relationship in this code, not the fact that a UTI is more complicated if I know the patient. It's the relationship itself that's being valued. So that's really cool. I'm going to do a little brief refresher, I hope, for everybody about the evaluation and management changes that happened in 2021 and 2023, because de-implementation is hard. It's easy to add new codes. It's really hard to take away practices that we've been doing for a long time. I mean, think about my annual PAP test, right? De-implementation of a PAP every year is really hard. So this is the equivalent in the coding and billing world. So outpatient E&Ms changed in 2021 and changed to be coding with medical decision-making or time. And inpatient E&Ms changed in 2023 to be the same. So I'm just gonna say a little bit about that, but the idea behind it was so that we stop writing so freaking much in the chart, right? Our notes were getting bigger and bigger and bigger. They weren't helpful for communication, for the patient to know what was going on. And so the idea was to pare this down to have a better note and system. So the most exciting part to me about the new E&M changes was you don't need a review of systems anymore. No more review of systems. There's no picture of review of systems, so the best we could do is ROUSs, if you've watched The Princess Bride ever. But you do not need to document a review of systems. Pertinent positives and negatives, those can go into your medically appropriate history. You don't need a family history anymore to be able to bill. You don't need a social history. You don't need all these organ systems and body areas and all those things that we learned about if you practiced before 2021. All of that is all gone, and it's just about what's medically appropriate and the medical decision-making, which is the actual work that we do. Other people can do a history, other people can do an exam, but physicians and practitioners are the ones that do the medical decision-making, and so that's where the work is and that's where the value is. So the way that it changed, new patient office visits, level 2 through 5, basically go through a straightforward low, moderate, or high level of medical decision-making or time. And there's no longer a minimal medical decision-making for a new patient because the level 1 code is does not need a physician. And inherently, if you have a new patient, they have to be evaluated by a physician to figure out kind of what's going on with the patient and are they complicated. But the documentation needed now for a history and physical is just what's medically appropriate, and everything else is about your decision making. And established patient visits, same exact thing. So 99212 through 215, same thing, medical decision making and time. So that changed in 2021, new and established. And then in 2023, we did the same thing with the inpatient hospitalization. So then it's initial and subsequent. So new and established, initial, subsequent, it's like your H&P, and then your progress notes every day. And so it's exactly the same. You've got your medically appropriate documentation, but really the medical decision-making every day is what's billed on, and the minutes change in the inpatient time. So I'm going to say a little bit about how to code with time with those, a little bit about how to code with medical decision-making. There's a lot to be said, so this is like a high-level refresher, and at the bottom of most of these is the link to the AMA site that contains the actual table. But I hope this is like an easy breather. Now that we wrote down 99459 and G2211, now we're having a refresher. So coding with time in the new E&M system, it's every 15 minutes for a new patient, every 10 minutes for an established patient. I can remember that. I can remember a lot of numbers, but most people can remember that too. And then hospital, it varies, and I look that up every time because I do slightly less time-based coding in the hospital. So the idea with time-based coding is this is the total amount of time you spend with this patient's care on the day you take care of them. So if you're like me, I have a cup of coffee in the morning, I look at my schedule, I'm like, who do I need to sort of check and make sure before this visit, what was their last thyroid test or whatever it is. But I take a couple minutes for some of the patients in the morning over coffee, and that's how I get my head ready for the day. I can bill for that time now if I'm going to use time-based coding. It doesn't have to be face-to-face time anymore. It doesn't have to be more than 50% face-to-face anymore. It is all just the total amount of time you spend. Time, though, does not include, because I'm a teacher, doesn't include all the time that I spend teaching people about all the different Palm-Cohen's for abnormal uterine bleeding that's not related to that specific patient we're seeing together that has a learning issue. Time doesn't include my travel time to my office, or if I'm gonna go to the hospital to round on somebody, like me going to the hospital and then coming to my office. So that's not included in the time. And it doesn't include other things that I might do in the visit. So say I see somebody, I do an evaluation and management, and I place an IUD. The IUD time doesn't include in the total time because that time is separate in the 58300. And they recommend that you document the amount of time you spend so that you can later on, go back and show that you've spent that time if you remember later. You do not have to say what you did in that time. I spent this number of minutes reviewing records. I spent this number of minutes on hold with the cardiologist to try to find out what to do with this lady's heart. I didn't, all of that. You don't have to write down the time, but all the time you spend taking care of the patient on that day. All right. And then medical decision making. So this is the other way to bill with the new E&Ms. And this is similar to the older medical decision-making tables where you've got the problems they come with, the amount of data you have to review to take care of them, and then the risk of management. So I'm going to talk about these briefly, and then we're going to do an example. So the problems addressed is about what diagnosis do you give the patient, and the risk of the complexity of the problem they have. So a self-limited or minor problem is something that if you did not come in and you really didn't need to see a healthcare person, like I cut my finger and it's healing fine and I just want you to make sure my finger's healing fine, that is a self-limited or minor problem. Contraception is not a self-limited or minor problem. If you do not get a prescription a lot of the times, you will have a lot of health consequences. It is an ongoing thing. You need to manage it for years. And so I think there's some education can be made for that because sometimes we downplay what we do, right? Do you have a yeast infection? That is not self-limited or minor. It's going to get worse. Just because there's over-the-counter medicines available doesn't mean something is so straightforward that you don't need to come. But low level of medical decision-making for problems, moderate, high, they're all sort of listed here. High might be somebody who you come in, they have a pregnancy of unknown location, they have some pain, you think they might have an ectopic. Like that is a high level of problem, and it's the complexity of the problem. The second column, so it's the amount of data that you review in order to figure out what's going on with the problem. There's no tests done in a straightforward visit. And in a low medical decision-making visit, it's really either ordering tests or reviewing test results, but you can't count both. So say I saw you last week, I checked your STD testing. I see you again this week, it all came back negative. I can only count that one of the 2 visits. I can't double count. So for low, you have to order 2 tests basically, or do some of these other things. For moderate, you have to get 3 tests or talk to somebody else, like the cardiologist you were on the phone with. And for high, you need 2 of the 3 categories. So it's kind of technical. ACOG makes a little grid that you can get, which is really helpful in my opinion. But we do a lot of test ordering, so that's the time I usually get my data. And then for my risk of complications, level 4 is writing a prescription. And so I just remember that. Everything else I look up, but if you write a prescription, that's a level 4 visit for risk of management. And so that's how I sort of keep those in mind. So let's do an example. We'll practice with this, and then we'll talk about the future, which is a fun time. So Kayla, this is a 25-year-old G1P1. We met her before because we coded the 99459 when we did her pelvic exam. Kayla's here. She has a vaginal discharge. She thinks her partner has another partner. You could write whatever additional important information in your medically necessary history, no fevers, has been happening for 3 days, doesn't have a smell, whatever you write. But medically necessary history is all you need. And you do an exam, and you diagnose her with trichomoniasis. And you document the parts of the exam that are important, not whether her sclera or anacteric. We don't have to do that anymore. so that's awesome. Like, that's my favorite part about all of this. And so you diagnose her with trichomoniasis. So when you go to your table, this is your diagnosis is your problem. And trick is an acute problem that doesn't have any systemic symptoms normally if you get it early enough. And so that would land in the low complexity of problem category here. All right, so for Kayla though, we're like, we think you have trick. I did a wet prep because they haven't taken away my microscope yet. And I love that because then I can, show people the flagella swimming and everybody gets excited. We do a chlamydia and gonorrhea swab, right? You have a discharge, we're doing a swab, but we diagnose you with trick, and so the CDC recommends we screen for other STDs too. You're worried about your partner. So then we draw some blood for some additional STD screening. And so that's 5 tests. Chlamydia and gonorrhea come together in one order set in mine, and so that counts as one test. It's not, if I order a CBC, I don't get credit for white blood cells and hemoglobin and hematocrit and platelets. It's all one test, like if it's all one test in a panel. And so, for my data, that's 5 tests that we ordered, and so that will get me, but I didn't talk to any other people. I didn't get it into the high box, but I am in the moderate complexity of decision making here, or for data review. And then I give her a prescription for metronidazole to treat her trichomonas. And because it's a prescription, that also is a moderate level of decision making. And so then once you've gotten your levels, the second highest one is what you bill. And so that is the second highest one for us is moderate. Kayla gets a 99204 plus 99459. So that's kind of how this works. The best part about it is not having to write as much anymore. We do not have to write as much anymore. So I just want to throw that out there. All right, there are a couple of other codes that I'm going to say a little bit about that happened this past year that are relevant to OBGYN. And one is neurostimulators. So there are 2 new neurostimulator codes if you do sacral nerve stimulators. And so those are the 64590 and 64595. 64590 is putting in or replacing the neurostimulator generator, the little device that goes in the pocket. And so if you do that, that's the code for that now for a sacral nerve stimulator. And then 64595 is just taking one out or revising it, but not replacing it with a new one. And so those are new codes this year. And all of the rest of the neurostimulator codes have remained the same, placing the electrodes, figuring it out, the temporary. But these are 2 new neurostimulator codes. I think the UroGyn's probably the most likely folks. I don't know if we have any UroGyns, but thank you and welcome. And then, so here are some payment policy updates that happened as well in this past year that went into effect. So first, remote monitoring services. If you do any remote monitoring services, like the patient has a thing that measures their blood pressure every day and sends you a little message and you have to look at their blood pressure every day, the remote monitoring services codes have changed with the expiration of the public health emergency. And so you only can use these for established patients now. If you have an established patient that you've been doing remote monitoring for the whole pandemic, and that's the only interaction you've had, that counts as being established. And you have to have at least 16 or more days of data in a 30-day period to report these, kind of every 30 days. So I don't know how many people are doing remote patient monitoring, remote physiologic monitoring codes, but these are the codes for those. Split shared visits. So this was another CMS rule. This has been a long time coming also, because the idea is you've got usually the time that I see this the most is in the inpatient setting. So there's an APP that's working, like a nurse practitioner or a PA in the emergency room, in the ICU, rounding on the floor, whatever it is, together with a physician practice. And so the APP is doing, they call it NPP, the non-physician practitioner, but so the NPP is doing a lot of work for the patient and the physician is doing a lot of work for the patient. And those are called split shared visits because only one person can bill for the visit. So how do you know who bills for it? And how this rule has kind of changed. I think it used to be the physician could always bill, but now whoever does the substantive portion of the visit gets to bill. And this is important because NPPs bill at a lower, it's like 80% of the physician. And so you ideally, if you're a person who's trying to make your practice sustainable, the physician is the one who bills. And so they've, after a lot of back and forth and work about, what is work and what is the physician doing, have come to a definition of split and shared. That's this one here. So the substantive portion of the service was proposed to be whoever spends more than half the time, which often the physician does a lot of very intense medical decision-making work, but does not spend more than half the time with the patient. And so now it's either more than half the time or the substantive part of the medical decision-making as defined by CPT, which is usually, I think, the case, unless it's a very straightforward situation and the NPP doesn't need a lot of additional physician work. But in the ICU or the emergency department, or depending on what your setup is like in your triage areas, this is an important one, which again was a lot of back and forth with CMS and advocacy about. So that was super in the weeds. Let's talk about new codes. So this is where things are starting to get more exciting, depending, more exciting. So this is the known future, the things that are coming in January 2025. So again, every 2 years, we've got some E&Ms happening. We had 2021, we had the outpatient. 2023, we had the inpatient. 2025, we have more E&Ms coming. So we're using our same medical decision-making table. But by now, we'll have enough practice and we'll be very familiar with this. So after a whole lot of work and back and forth and surveying and whatnot, we have telehealth codes coming in 2025. So no longer will you use your 99213 and then append a modifier like modifier 95. There will be separate telemedicine codes that are coming starting in January. So there's going to be 4 codes for a new patient for audio and video visits. And we don't actually know what those numbers are yet for the codes. So the timeline of this is the AMA publishes the final sort of RUC results, and the codes are like 90XX3. And so you don't actually know what the X's will be in the future. So we don't know what the code numbers are yet. That's coming in November. And then the AMA puts all of this information out to CMS, who finalizes everything, also in November. And then between November and January, there's a ton of horse trading or advocacy or negotiating or activism happening to try to help make that rule better for us. And so these things are coming. We know the codes are happening, but there's some details which we don't know yet the answers to. But there's going to be established virtual visit patients with audio and video, new and established. There's 8 codes like this. The new patient codes are going to look exactly like the in-person codes in terms of what do you have to document, how much time, the level of medical decision making. And we just don't know the code number yet. And the same thing for established patients, the same number of time, the same number of medical decision making. So that's 8 codes already, brand new and exciting. Now we have 8 more brand new and exciting codes for when you cannot get your stinking video to work. And so if, this is actually untrue. If you try super hard and you can't get your video to work, I think you still get credit for the video. But if the patient is like, no, I want to have a phone call because I can't figure out how to work the Zoom because my kid set it up, but then it broke, and then the cat filter came on and all of that. So they're like, can't I just have a phone call? So now there's a phone call virtual visit code as well. And so these are the audio only visits. These codes, same idea, new and established, and the same time increments count. But you have to have at least 10 minutes of medical decision-making phone call in order to bill the phone call only codes. So same idea though, the medical decision-making is the same, the straightforward, the low, the high, the minutes are the same. And so the idea is that this is medically necessary minutes that you're spending on the phone, and not like the G2211, like how are your kids doing and what did you do over the summer and all of that, right? Which is important for longitudinal care, but not for these. And so the same thing for established patient. But then we have a lot of medical decision-making phone calls with patients that are less than 10 minutes long. So there's a virtual check-in code that's coming too. So if you have a 5 to 10 minute conversation with the patient, then you also can bill this one as well. The idea with this though is it's not like calling to tell you your swab came back and I'm sorry you have chlamydia and yes, it's an STD and I recommend you get tested and your partner, you have to talk to them or your partners. And right, because that is a test that we did related to a visit we just had within the last 7 days. But really, like, it's a standalone kind of virtual check-in that either is separate from a visit you had more than 7 days ago, or isn't like, hey, I'm feeling super sick and I have this rash and whatever, and you say, come on in, sounds like you're sick. So you can't just call the patient and then have them come in to see you that same day. That also doesn't count as a virtual check-in. It really is like a doctor's visit over the phone, but a short one. And so that's another exciting one that can be coming. There are some other new codes that were a long time coming. If there's any gyn-oncs in the room, I know there's gyn-oncs in the room, just like I know there were urogyns in the room. So there are some codes for intraperitoneal tumor excision or destruction. There's already codes for primary peritoneal cancer, but there are other tumors which are primarily in the peritoneal area, so like a mesothelioma, a giant, in theory, like endometrioma arising from the sidewall, something like that. And so there are new tumor excision codes for that. And they have to do with the total sum of the size of the tumors. So if you've got 100 million itty bitty little tumor specules, and you add them all and they're more than 30 centimeters long, then you bill the 30 centimeter code. So that's the idea, you sum the amount of codes. And then there's another code for HIPEC, the intraoperative hyperthermic intraperitoneal chemotherapy. And so HIPEC is something I would think that only gyn-oncs are doing. But I would be super excited to hear about your practice if you're doing it. You're not a gyn-onc. And so the idea with HIPEC, right, is you like remove all the tumors. This is a non-gyn-onc talking. Remove all the tumors, put the chemotherapy in, like slosh it around while the patient's in the OR, and because it's hot. And you have to monitor them and do the work, and then however long that takes, first 60 minutes, additional 30 minutes, and then you like get rid of all the chemotherapy there and close them back up. Is my impression of the context. So now there's a code for that. This is a new procedure relatively, and it took us a long time together with the American College of Surgeons to get this code, both of these codes. So we're super excited about that. And then there's one more new code that's applicable to us that we've been hearing a lot about, and it's the practice expense for medical genetics and genetics counseling services. So genetics counselors are not licensed clinicians that can separately bill for their care. And so if you have a genetics counselor in your practice, you know this, you're highly frustrated, there are genetics counseling codes, and like basically what they're doing is having these long, complicated conversations with patients so that the physician doesn't have as long of a complicated conversation and can bill. It's like a sustainability thing. So now there's a code for the practice expense of a medical genetics counselor. And so it's each 30 minutes of time, but because they can't bill independently, it's a practice expense code. So that's also super exciting, and that's coming. And there will be, I want to say it's November like 21st through 23rd, if that's a Wednesday, Thursday, Friday. The AMA is doing a 3-day online virtual like webinar about all the new codes coming and exactly what they are and going into detail. I've only pulled out the ones that are relevant to us, and the OBGYN and kind of urology often go together in the half day. So you're welcome to sign up and attend that if interested, and they also put out a bulletin. Like, there's a lot of educational materials. All right, so these are the codes coming. Now this is the unknown future. And so this is the most exciting future that's happening. And this is the part where I need you all, we all need everyone to engage together in this. So I'm just going to say a little bit about the history of CPT. January 1st, 1966 was the first CPT book, and there were 3,500 codes or so. And now, well, this is 50 years later, so this was the 50th anniversary. There's more than 10,000 codes. There's a lot going on. Every time there's a new procedure, there's a new code. And so this has been an ongoing work, and it's a continued ongoing work. So number one, if you have a coding problem, if you have a payment problem, if you have a policy problem, ACOG is collecting all of those, and that really helps the organization know what's going on with the membership. It can be a specific payer, it can be a specific coding issue, but this is the first sort of place that we get anecdotal data about what do our membership need. And so acog.freshdesk.com is the payment policy and advocacy portal. And with this, you can see also what other people's questions have been, like, hey, this thing happened, and, you know, the baby was out to like the chin, but, you know, what can I bill there? That kind of thing. And so this is a great first step for advocacy. The next thing that you got to do is take surveys that come from ACOG practice, because these are how we get our members' payments going. They look spammy, right? Reminder, take the ACOG compensation survey. But anything from ACOG practice, the only things that come are really important payment surveys. So based on all the members' questions in the portal, and based on this survey that ACOG did in 2022, this was the presidential initiative of Marty Tucker. If you guys know Marty Tucker, he loves payment as much, probably more than I do. But he was like, we need to get paid for the work that we do. So ACOG came together, made a presidential initiative about how do we get paid better. And it had two arms. One was equity in GYN payments, because, right, there's a perception that, like, we do the same procedure as the urologists, but they get paid more. And so there was a lot of work that happened on the GYN side related to equity in payments. And from this, the pelvic exam code was one of those outcomes, because it was clearly inequitable that if you do a pelvic exam for an E&M problem, and it takes a whole lot more expense and work, you know, and we're not getting paid for that. So that's where the pelvic exam code came from. On the OB side, the membership clearly said the thing that's hurting us the most is the OB global, like the global package. And I see a bazillion heads nodding in the room. So this feels true, right? The OB global, like 59400 is us doing a ton of work for like 12 months and waiting to get paid. And there's nothing else like it in medicine. And so ACOG recognized that the OB global, the membership was very clear, like that is the OB thing to work on. So now I can tell you about like the publicly available things that have been happening. In February 2024, there was a request for a tab at the CPT editorial panel that was called Maternity Care Services. And it was rejected. And that's what we know about that. And we know that in June 2024, the CPT editorial panel created a work group about maternity care services. That was the result of a code change application that came forward in February. And so right now, the CPT is working on maternity care services, and the idea is to bring forth a code change application with changes to the Maternity Care Services Code, and propose new codes that reflect the current practice of medicine. And as you all know, right, like whoever's providing the office visits and then the patient moves and then you're having to try to keep track and then you've missed the timely filing because they moved. You have people who are being induced at 39 weeks based on the ARRIVE trial. Everyone's trying to reduce that primary C-section. ACOG recommends that labors last longer so that we can try to reduce that primary C-section. There's a lot of work being done about the length of labor. All of the work of labor management is different than it used to be when the codes were made. And so, and like who cares for the patient postpartum and how many postpartum visits and all of those things that the global does not really address just because the practice of medicine has changed. So ACOG is acutely aware of all of this and is advocating at the CPT in the maternity care services work group for this. And I think I'm allowed to say, because the meetings are public, there are two ACOG reps on this work group. One of them is Dr. John Horton, who you may know from Emory, and the other one's me. And so there's a lot of advocacy and work going on here, and all of the meetings that are public, people have shown up, like OBGYNs have shown up and given public comment, and it has been really powerful. And so if there are more meetings to be scheduled, it's on the AMA website, it has helped to see the sausage being made. Like, I think that helps everybody because there's a whole lot of considerations. Like, the language needs to be consistent, and we have to, like, be comprehensive, but not overly excessive. But this is the still as yet unknown, but hopefully positive future that we're sort of helping to shape. And everything that you all can do as well is really important. So your advocacy, here's my charge to all of you. Number one, join your medical societies. Kathy Bonk was right. This meeting, like, the New Mexico section of ACOG is itty bitty because New Mexico is not a state with a lot of people, right? There's like less than 2 million people in the whole state. And this meeting is fantastic. So join your medical society and advocate with your medical societies. And all the things aside, like the way we get paid is through ACOG advocating to the AMA. The way that you can affect change is through membership. And so I recommend to everybody to join and be active in your medical societies. The number next is to complete the code valuation surveys. So I'm going to go do a little story time about what this means and all those spammy emails. So the way that a code gets valued, you make a code, we'll call it maternity care services, just for an example. You make a code, and then you have to survey everybody to figure out like how much work is involved in each of these codes. And so this is a survey that goes out to membership. It looks like spam. It comes from ACOG practice, and it has the word survey in it. And it says something like physician work survey, insertion of cervical dilator in your, or neuromodulator stimulator code. It looks like spam. If you get something from ACOG practice that says survey, please take it. And this is what the survey looks like. It says, Dear Dr. Hofler, we need to review a CPT code, click here. And it's going to ask you, how much time do you spend to do these different things and how much work does it take? And they are not asking you, what is your fastest ever? They're asking you what is the typical amount of time that it takes, right? So how much time do you typically spend with someone who is a null-up, who's being induced for 3 days or whatever it is? How much time does it typically take for you to, whatever it is? But thinking about how much time does it typically take? We underestimate time. This is why I'm always late, right? I underestimate how much time it's going to take me to get somewhere, how long it's going to take me to be in the room with the patient. I try. I have timers, I have strategies. But the idea with the survey is, think about your typical patient. Think about how long it actually takes you to do work, because we have a finite amount of pie, like money, in the pool of CMS, and everybody's trying to like get their share. And so when we do surveys, the important thing is to like be very realistic about how long it takes you to do stuff. So that's the other sort of advocacy piece you can do. Complete the survey and like think about how long is this. And then after that, the AMA makes recommendations to CPT, to CMS, and then CMS decides. So when this cervical dilator survey came out, the worker reviews of cervical dilators was 59200. This is like laminaria or Dilapan. It's the code that a lot of people use to put in balloons for cervical ripening. And it was 0.79. And after we were surveyed and everyone did the survey, the ACOG recommended 1.2 RVUs. That's what got presented to the AMA. The AMA recommended 1.2 RVUs to CMS. CMS accepts like 90% of the recommendations, and so I would be shocked if in November when they tell us that we don't get 1.2 work RVUs for our cervical dilator instead of 0.79 now. So that's an example of it working nicely and the system. So you might see something come through in the future. I don't know when. The future, this is the unknown, exciting future. That's from ACOG practice that says survey. Please take the survey. And so the last advocacy I just want to say is a bigger one. ACOG has partnered with Vote ER. There's a table that's right across from the Emory at Grady table. HG is there and excited to tell everybody about Vote ER. My home institution, which is pretty awesome because we're the state of New Mexico, but UNM Hospital is partnering with Vote ER to try to get people registered to vote because this is like the hospital, the physician's office, the urgent cares, wherever. This is a place where literally everybody has to go. And so literally everybody can get reached to try to register folks to vote, because that is the other really important thing that we've seen over and over. And that, isn't quite as related to billing and coding, but kind of is. So vote and partner with Vote ER to help everybody vote. And thank you.
Hi, Sandra Reed, and I actually served on the RUC for 16 years, but recently we got a snippet about a bill that has been dropped in Congress to work on budget neutrality. And one of the issues that physician payment, the reason the pie, there is a pie, is because we all function under budget neutrality, and there's only so much money in the pie for physician payment. So when one group's codes go up, everybody else's codes go down. What is the likelihood that we are going to get any meaningful legislation passed to get rid of budget neutrality on physician payment, and what can we do as advocates for this to explain to our Congress what we are practicing under and the limitations on physician payment? We're the only group that has to practice with no increase in payment.
Yes and yes. You are 100% right. So this is like the even more unknown future. What's the likelihood of this bill to pass? We all hope so, right? Because you're absolutely right. The narrative is that the rich doctors are greedy and should only have so much of a pie. And if you see, the AMA has been doing a ton of work on this over the board, where there's a beautiful graph. I should have stuck it in here, but it wasn't quite as relevant. A beautiful graph of all the different healthcare payments over time, right? And physician payments have sort of stayed level and gone down even if you account for inflation. And facility hospital payments have gone up, and pharmaceutical payments have gone up, and all the other payments have gone up because of that. And so I think number one, vote. Number two, money talks. And so this is a conversation that we have all the time. The trial lawyers, the the med mal people, donate a ton, at 100 times the rate that we do to political causes. And so their narrative is heard at 100 times greater. Even if we have this professional platform, even if we're physicians, that is the reality. And we've seen it come through in who gets elected. We've seen it come through in which judges get elected and appointed. We've seen the implications of not engaging as strongly in the political system. And so I think, again, talking to everybody and also framing the messaging as, countering the greedy doctor is trying to make $1 billion, because I'm a state employee, right? My goal is to take care of all the New Mexicans and teach all the learners. And like, I hope that we can be sustainable and break even in the process. And that's why this is important. But yes, keep voting, keep talking about this, because this is one of the hardest parts right now is budget neutrality.
Teresa Bird, thank you for this, and I really think this is something that new grads need when they come out. I mean, I've been practicing for 20 years, and I still don't understand coding and billing, but I just wanted to say, too, I sit on an advisory board for an insurance company, and just last week, the CEO asked me, he said, we have these incentive codes for obstetric providers, and they're not using them. I just want to just tell all of you to offset the cost of the global billing for OB services until we get better reimbursement. Some of your insurance companies have maternity care services extenders. So, and some of them are things like if your patient establishes care in the first trimester, you get a one-time $75 reimbursement, which might not be enough, but if you see a lot of patients, it can be something, $100 for at least one postpartum visit. And then like an additional $10 if you do their postpartum depression screen. So it's not necessarily much, but that's what, $200 per OB patient that you're missing. And some of these insurance companies are trying to do that to incentivize us to really get our patients to come back and come in early. So I would just encourage all of you guys, the payers that you guys, any insurance companies that you're on, to reach out to them to ask if they have any maternity care extenders and get like a sheet on it. And it might be good for us at GOGS. I know I'm just adding on more stuff for us to do, but potentially to put together something for the Georgia carriers so that we could send it out to them, because again, the CEO was like, we want them to use it, but nobody's using it. So that's it.
So we have one more question, Dr.
Okay, there's a much bigger issue here, and the issue really gets down to money and healthcare disparities, because the way it works is that states have balanced budgets, and they are unwilling to put money up front into improving maternal and neonatal care, and they would just rather spend money down the road. And when you have a mother who's got a chronic illness secondary to pregnancy or a damaged neonate, and the issue is to convince state governments and federal governments that if they put that money in on an annual basis, they would save $3.85 billion, and that's not chump change.
Absolutely. And I hear there's going to be a talk with legislators tomorrow. So this is the other place for advocacy more locally.
Thank you so much.
Hold
on, that was my comment.
This is a commercial for the.
No, look,
Okay.
we do. We have our legislators here tomorrow. We have Chair of Appropriations from the Senate, Chair of Appropriations from the House, and we have the Rules Chair. They are here with their time. Everything you just said, money is the answer. What's the question? And it is what it is. And these guys have taken their time to come, and Representative Parrish, who's the Rules Chair, nothing moves unless he moves it. I mean, it just doesn't happen. If it's something bad for us, he can hold it back. If it's something good for us, he can push it forward. But he needs to hear from us. He needs to hear from us. They need you all to speak to them, thank them for coming. But everything you just said is 100% correct. They also need your check. They need to get reelected. These people were invited not because we don't like them and not because they're not friendly to women's health. They were invited here, handpicked by our lobbyists, because they have been so easy and so wonderful to work with. So thank you so much. Thank you for the time. And I was going to say this, but you did a wonderful job, and I appreciate your talk about everything.
Yeah, I just had a quick question. It's my understanding that the reimbursement for telehealth visits dropped after COVID. I've not been able to find any use for telehealth visits in my practice. Are many OBGYNs performing or utilizing telehealth visits now, or has the reimbursements gone up?
That is a great question. You know, I don't have any data about how many OBGYNs are using telemedicine visits per se right now. In New Mexico, it's really helpful because sometimes people have to drive 3 and 4 hours to get to any healthcare provider that does, you know, prenatal care or whatever. And so that's really important, having a telephone option, because the internet is not fabulous. But you're right, what happened was the facility portion, if you work in a facility setting, kind of went away for the facility fee of those visits, and so a lot of people's health systems de-incentivized those visits too. So it depends on the patient. Like, there are some people for whom intermittent telemedicine prenatal care is really helpful. There's some people who love to, check their blood pressure and then send it in and then bring you a graph and all of that too. And so those kinds of care, I think we're just not thinking about because of the global. And so it becomes a little bit more complex. And I hope that people have taken advantage of virtual visits for post-op checks, because those are a lot more convenient for people who are having surgery. If, you can look at the incisions or check in on the phone, and then bring someone in person if there's an issue. But I see that happening a lot, is virtual post-op checks to, let me see your incisions, is easier at home than schlepping into the office like 2 weeks post-op.
Can I put the question to give the audience? Sure. How many people are utilizing telehealth visits in their office? Mas or menos, okay. Good, thank you.
Thanks. Okay.
Thank you.
Thank you, Dr. Hofler. There will be a QR code in between the sessions to submit questions for the legislators tomorrow, and that starts at 7:30. Do not stay out too late tonight. Make sure you come to that session.